if you will remember in your pre-read, those 80 pages, there was a domain focused on implementation science. And though we're not going to have that breakout this afternoon, we did want to focus on how that affects patients. We wanted to focus on implementation science in a panel format today to allow you to hear from clinicians that are treating patients in a variety of different settings, because that's, of course, very important to our R&D. And so I'm excited to kick off this panel. We have Noel Gunther, who will be our moderator today, and we want to thank you for being here, and he's with BrainLine. We have Uzma Samadani, who is with the Minneapolis VA Medical Center. We have Christopher Whitlow with American College of Radiology in Wake Forest, and Dr. David Cifu with the VA, and Dr. Thomas DeGraba with NICO. And thank you all for being here today. And Noel, I'll let you get started.
Good morning, and this is going to be a slide-free presentation. And I'm going to ask a few questions of the panel to get things started, but we're going to welcome questions throughout, and so please jump in. Really welcome getting your questions throughout the day. Doctors Haas and Brady have laid out a really ambitious agenda for us, but in this panel we're going to focus more on the here and now. The CDC estimates that about 2.8 million people sustain a TBI every year, and we're going to focus on how doctors and hospitals can do a better job of treating the patients and families who are in front of us right now. How do we do the right thing for the right patient at the right time? And though I think we're all keenly aware, especially on the basis of the last couple of presentations, of the limitations of existing treatments, I want to start maybe by focusing on what we're doing reasonably well now, with the best clinicians at the best treatment centers, using the best guidelines available, where are we doing at least a decent job of treating the patients that we're seeing right now. And I'm wondering, Dr. Cifu, we might start with you.
Yeah, thank you, Noel. I need to start off first by just noting that as an avid vegan, we need to stop the whole eating the elephant thing here, all right? Let's go with broccoli, tempeh, or some kind of fresh fruit, okay? So no more elephants, no more eating flesh, if we can. For me, that's okay. All right, moving on. But as a general overview, I think the most important thing is if Dave Brody's great vision comes through, and we're not gonna at the same time have a plan to implement it across even at a wonderful VA. I work at a fantastic VA in Richmond called the Hunter Holmes McGuire VA, state-of-the-art polytrauma. Everybody is board certified in anything possible, super specialists, full interdisciplinary team, integrative health, whatever buzzword we want to use. I mean, we're doing it all. And they're not buzzwords, I apologize for that. Well, we're state-of-the-art, it's great. But even within that team, there really is a disparity, despite ongoing education, disparity on, what's your intake look like? Whether that's an acute concussive injury, an acute moderate TBI, or a chronic, just the intake alone, even though there's standardized forms. So I think, I'm really fixated, and I think I was the one who actually made them put implementation science on the 2-day agenda because it wasn't there. I'm like, we've got to really put our eyes, all focused that when we come up with these treatments, hopefully evidence-based, hopefully really knock it out of the park, couple doubles, triples, home runs. If we haven't planned on how to get the masses of clinicians to understand it and then to figure out ways to actually put it forward, can we get those MRIs? Can we get the appropriate machines, medications, as well as getting buy-in? We haven't heard this yet. Getting buy-in from the veterans, the patients, that they're going to say, yes, we are all in to do this specific exercise protocol, or become vegan, or to get to do all the courses of the TMS, the full program. We're not going to have any chance at success. And so that process really should start with this meeting, or if it hasn't already. The implementation science is just as vital, because there's already singles out there. Dave Brody's pointed to some, and we all know of things that are either evidence-based or we feel very comfortable as clinicians that this is a positive outcome that is not universally accepted. Even at what I think is a premier VA, and I come from an institution at MCV-VCU that's been doing this for 40 years, we don't have standardization there or full knowledge. And I take blame for that because I guess it's my job, but I'm working on it. But So, if we think of as we get further away from these major medical centers, we're going to have even more. Again, that doesn't mean not doing it well, but it's going to be, we have greater differences. And while I understand differences and every patient's unique, if we don't have some standardization, it's going to be a big fail. So I think we are compassionate. I think we're getting the concept of holistic care and integrative medicine. We're getting that well, no. But we're not actually doing things that are even commonsensical standard. We're not doing them in a standard way. And so I think that needs to be something that is integrated into every discussion we're having here. Even translating it, like what if we're better at translating it from the animals to humans? If we're not then implementing it and having a partnership with the patients and families, I think we're failing. So that's just to start off. But broccoli, not elephants. Yeah, I'm sorry.
Watermelons.
Well, watermelon, that's okay. A little rum in there, maybe.
Okay, Dr. Samadani, want to build on those culinary metaphors? What could we be doing? How could patients be getting a better diet of care than they're getting right now?
Well, I don't do culinary metaphors, unfortunately, so I'll have to stay away from that. But I do want to say a couple of things. So I work at Minneapolis VA Medical Center, and that's where I base my brain injury research lab. And then I also work at a level 1 trauma center where I do see patients acutely with brain injury. And I also do a lot of community work where I talk to people in the community about brain injury, particularly in sports. And so I get exposure to a large cross-section of our society. And what I have seen universally among the veterans in particular, among the civilians who come into the Level 1 Trauma Center, and among the community people is that there is a vast and wide perception that brain injury is not treatable. And that you don't need to come to the hospital because they're not going to do anything anyway, as long as it's not life-threatening. And then that's sort of, to some extent, reinforced by our existing systems. Because when you do come into the emergency room, the goal of the emergency room is not to classify the pathophysiology of your problem and set you up for an appropriate treatment. It's to figure out, do you have a life-threatening problem that needs to be admitted and you need to go to neurosurgery, or can you go home? And there's really nothing in between. So there's no classification of the pathophysiology or any sort of evidence-based anything that happens at any triage level when a patient comes into the hospital. And that's really, I think, the fundamental problem. So, I know that there is huge concern about direct-to-consumer testing because it's a free-for-all. There's lots of people who are trying to do it. But the reality is that a majority of patients aren't seeking treatment in the first place, and many of those go into a death spiral. So, we already heard about it from the very, very first speaker who talked about how it affected his employment, his social life, his psychosocial constructs. It basically became a self-medicating, addictive disorder problem. And we see that. We see that in people who don't seek care. So I think what we need to do, and obviously I'm just framing the question in very, very similar ways to people who have framed it before me, and how many other people are also framing it, is we need to figure out solutions that will not only be helpful in the acute medical care setting, but then also ultimately also be translatable to the community, where they can be potentially used as direct-to-consumer. And whether that's app-based solutions or eye-tracking-based solutions. Obviously, full disclosure, Dr. Stuart Hoffman funded my research at the VA in 2010. It resulted in a diagnostic for concussion that got FDA clearance in December 2018. Aid in the diagnosis of concussion using an eye-tracking neurodiagnostic. So I have that conflict. I do believe that we have to find solutions that are translatable from the medical setting to the consumer setting. And then once we do that, then we can move on to classifying the nature of injury and doing the things that Dr. Brody talked about, such as trying to treat the right symptoms with the right treatment. So, for the patient that has an anoxic component to their brain injury, we should be doing the wild and crazy things like stem cells and, transgenics and, other types of therapies. And for the patients who have less severe injuries, that are associated with some form of, some amount of spontaneous recovery, we can do less invasive and less risky therapeutics. And so I think that we have to find that spectrum, But first, we have to classify the nature of the problem.
Well, I can hardly think of a public health problem where the translation of best practices across the country is worse than it is for brain injury. And I'm wondering, why is it so hard with brain injury? And what are some steps that we might be able to take to make things better? So if the people are not showing up at one of your VA centers or Wake Forest or NICO, they're getting at least a reasonable level of treatment when they show up to see their pediatrician or their general practitioner or wherever, the social worker, wherever they may see first if they have a brain injury. What can we do to start making that system better? Yeah, sure, go ahead, and I'd like to hear others jumping in as well.
Well, I think what we do know, and there was a paper that came out of Children's Hospital of Philadelphia that showed that 80% of children who have a concussion actually go first to their pediatrician. Mm-hmm. And the interesting thing about this is that pediatrics residency does not have any required brain injury education in it. There's none in med school. I used to give the only lecture at NYU, a 1-hour lecture on brain injury. There was no other speaker on brain injury in the NYU medical school curriculum. Then when they get to residency, there's no required rotation on neurosurgery, there's no required rotation on rehab. The only doctors in medicine that have required rotations in brain injury are neurosurgery and rehab. Orthopedics has a trauma rotation, general surgery has a trauma rotation, so there are other doctors that are exposed to trauma, but no one is specifically exposed to brain injury in medical school, and that leaves a huge gap. So I think it was 77% of pediatricians do not feel comfortable treating a patient with complex post-concussive syndrome. And a lot of the problem is that we are asking doctors, who treat everything from, at this point, measles to, diagnosing, early childhood diseases, and, they're dealing with a huge spectrum of pathology, and we're asking them to suddenly become specialists in one of the number one cause of morbidity and mortality in children. So, obviously we're asking them to fill huge shoes, and they may not necessarily have the training for it. There's obviously acute awareness of this. I've talked to, Bill Meehan and Tina Master, and some of my best friends are pediatricians. And they have worked with the American Academy of Pediatrics to build CME there. But it's true across all primary care disciplines. So emergency medicine obviously does have an acute care component, so they do see brain injured people quite frequently. But it's not as if there's already an established curriculum in that, and there needs to be. I think that there has to be greater awareness that these problems are classifiable and treatable, and that the treatments range across a spectrum. There's cognitive, behavioral, occupational, speech. There's ocular, motor, vestibular. You've got to figure out the problem and then treat it.
Dr. Whitlow, would you add to that both the challenges, but also maybe point towards some plausible solutions or first steps?
Sure. So I'm a neuroradiologist, so I see all of the imaging that's generated at our level 1 trauma center, which is extremely busy. I think to reflect what some of our other moderators have said, I think we have pretty good protocols established for dealing with severe trauma. So if you come into our emergency room or any level 1 trauma, we triage our patients. One of the first steps, obviously physical exam is always a first evaluation to see what's going on. Imaging plays a second role in looking for the effects of trauma and identifying situations that need emergent surgery. So if someone gets a head CT and you have a giant subdural hematoma and they're herniating, they get whisked away to the emergency room to get a life-saving decompression. But so we're, and there's standards and guidelines for how to proceed in those kind of situations. But I guess what I'm struck by are all of the patients who come in, like Magali and the other people who are talking about their story, and they came in and they had, a head trauma, presumably brain injury. In that setting, I was on call this weekend. I had a lot of people who maybe fell, hit their head. I'm presented with a CT. Well, there's no giant hematoma to intervene on. There's no herniation. There's really nothing that I can see, and yet they're symptomatic. So there are limitations to the tools that we have. And what happens to those patients, when they leave the emergency room? You're exactly right that the decision tree is, do they go to the OR or do they go home? But yet they still have this problem that needs care. And for a lot of patients, there's no infrastructure to take those kinds of patients in and to manage their symptoms or to even consider therapeutics. Part of that, might be that there's no way to stratify them, like Dr. Brody was saying in a lot of times, in terms of, here's a patient who's had some sort of brain injury, they're symptomatic. 60 to 90% of those patients will get better spontaneously with no intervention. But what about the patients who don't? Can we reliably identify them? Do we have to wait 6 months before we know that their symptoms are going to persist? During that time, you've lost a lot of ground in terms of intervening on the pathophysiology, which we're still trying to understand, whether that's neurovascular coupling or autonomic regulation of blood flow or whatever that might be. Are there methods to try to stratify them? I think, like Dr. Brody was saying, imaging might play a role in that. If you can do it for individual participants, which is really difficult, individual patients, it might be a combo, but physical exam always is a great way to go. Whether that's sensitive enough at the very early stages to be able to identify someone who's had a brain injury who's going to have persistent symptoms or not, still yet to be seen. Is it some kind of blood test? Is it some genetic predisposition? I think there's a lot that we don't know and a lot that we can discover to try to build those kind of pathways for these patients, who need our care beyond just the severe trauma patients, who have their own challenges as well.
Yeah, we get emails from BrainLine literally every day from people who the medical system has said, well, you're better, you're good enough. And what we hear from them is, well, I'm not really better. I'm kind of better. I'm sort of better, but I'm not myself. And that's just an army of people out there that there sort of doesn't seem to be any good way of working with them right now. And I'm wondering if any of you have reflections of how we could serve that enormous number of people better than we're doing today.
Tom?
Yeah. So when this conflict, or the conflict in Iraq started in 2003, we were prepared for the severe head injury, just as people. We knew what that looked like. We knew what the resources were that we needed. What we weren't prepared for, and we didn't have the understanding of what was going to be a wave of intense need, was that exposure to repetitive mild traumatic brain injury, concussive events, subconcussive events, both with in-theater operation injury as well as in garrison training that exposed service members to TBI. In 2007, 2008, there was an understanding there was going to be a need to really understand this population better. And it was more than just understanding some of the neurological constructs that we originally had thought about, but understanding that change in personality, that change in behavioral health events as the comorbidities, and requiring a more comprehensive approach. What NICO put together as a proof of concept in 2010 with an interdisciplinary care program allows us to harness over 17 different disciplines to be able to take a look at the whole patient, everything from the neurological, the behavioral health, the spiritual, as a component of getting the service member back to the person that they want to be, and being able to utilize those elements at the same point in time, as opposed to exploring their headache 1 month, another month later exploring their sleep disturbance, a year later exploring their behavioral health problems. If you can get a composite and understanding, then you can create a treatment paradigm that actually puts into play a treatment for each of those things that will affect the others. And it's that interplay of those symptoms and of those disorders and those neural networks that are disrupted, that if you don't create in tandem, you have a much more difficult time getting an increase in recovery in any of the individual reductionistic approach to medicine. So our goal was to put those into play. Using integrative medicine is a component that for us has been extraordinarily successful, mainly from a standpoint of being able to address the issues of how TBI and the behavioral health comorbidities are intimately overlapped. The disruption of the autonomic nervous system, that increase in irritability. Magali put that picture up with all these different symptoms, and almost right in the center is irritability. And all our service members will say the same thing. If I had to pick one of the top 3 things to change about myself after 10, 15, 20 years time in service, it's the ability to control that irritability that stops me from being the person I want to be and interact. And a lot of that has to do with the differences of the personas themselves, who they are in theater of operation with their unit on a mission, who they are at home, and those personas that need to be separated, requiring cognitive bandwidth to keep them separated. And so utilizing both a strategic interdisciplinary approach and then utilizing that in multiple centers, and that's one of the things that we've been able to do now, 7 centers that are satellites to the NICO, Intrepid Spirit Centers, utilizing that same interdisciplinary model, synchronizing the assessments to be able to find those subpopulations based on the interdisciplinary care approach allows us, I think, to be able to start having a better understanding of which patients will start responding to which therapies.
We're about halfway through the session. I'm wondering if there are questions already. And yes, sir.
I tremendously applaud the more holistic approach that you're talking about on the stage today. But what I'm wondering about, while it works very well, and we're all very grateful for the fact that it does work very well for our veterans, what about in the civilian population? It doesn't seem that we're really addressing the fact that who's going to pay for all this? Are the insurance companies going to pay for all this chronic care? We're faced with tremendous disruptions in the Affordable Health Care Act right now. What do you see as the future? Your plans are great. The ideas are fantastic. They're well-deserved and long overdue. But has any attention been paid to who and how these programs, if they're to be successful, who's going to pay for them?
Can I take that one? I would just make one comment on that. I personally, my opinion, and obviously this is only an opinion and no one can predict the future, I think that the future of that is going to be elimination of the insurance system by big data. Because what's going to happen is when Google, Berkshire Hathaway, Amazon, their big company Haven establishes that using big data, that particular treatments, for example, work better for particular conditions, then they don't have to go through the insurance companies. They go directly and they pay for it, right? So if you can figure out, for example, that if your employee who had a brain injury is going to benefit from treatment X, Y, and Z, then you will pay for it, and it'll be employer-based. And that's what I think the future will be ultimately elimination of the insurance companies, because they're basically just a great big nothing taking out money.
But if you're not, the problem
Anyone else
is,
want to throw a bomb?
Yeah. Thank you, because I'm the one who says that and I get in trouble, so bless you for saying that. I totally agree. And certainly in the VA system,
Yeah.
it actually, it's reversed, because the more we can keep this population healthy with wellness, and by putting them into standardized protocols that are looking at diet and lifestyle changes and intermittent specialty care when they're getting a flare, or if there's something that is specifically challenging. But if we as the experts, as well, and that includes the patients and the families too, if we as the experts can't come together and create simplified care pathways from what we already have and what we're going to add to it, this problem isn't going to get well. More complexity and scaring our pediatricians and our family medicine that, oh, you have to send them to a major medical center because they're 2 weeks out from a concussion, or 2 months or 2 years, and they're not getting well. We're going to try to get everybody to major medical centers or to have monstrous procedures, and we are going to bankrupt. We're already bankrupt, so we're going to more bankrupt. But in the VA system, the polytrauma system of care, set up at the same in parallel with what was in the NICO, has been set up to have standardized protocols. But we can't give them ones because we haven't agreed as experts yet on what they are. I mean, I've been part of writing 2 CPGs that haven't been well accepted because 2 weeks later, someone says, oh, that's not evidence-based, or there are 6 other ways to do it. So we need to, at some point, have agreement, implement, but then realize that prevention and chronic care management pays for itself without insurance companies, and the VA system works. But simplify and stop. I would advocate, please, let's stop threatening every patient with concussion with dementia. Please stop doing that. It's not going to happen. They're going to get dementia from eating elephants. They're not going to get dementia from one concussion. But I understand it gets people excited, engaged. But can we please have a more positive outlook and say, if you do these things, you're going to have a much less risk, a much lower risk. So,
Why don't we talk about what some of those things are? And I'm sorry, Dr.
Yeah, and to that point of evidence-based, and this is where it becomes important with regards to, and that this question is critical. When you start taking a look, particularly at integrative medicine, where people say, who's going to pay for that? Well, one of the aspects and the things that we're trying to look at, first of all, is how do you make your patient self-efficacious and self-advocates? And as part of our program, we have two main components to our integrative medicine. One is actually a creative arts component where we look at art therapy, expressive writing, which really has had some incredible benefits and really is extraordinarily low cost to have a pad of paper to be able to write. And on top of that, instead of just utilizing those particular modalities, be assured that it's tied into behavioral health care. So as you start peeling back the onions, whether it's through art therapy, whether it's through expressive writing, there has to be guidance through that system. But it's something that has low cost and can be done anywhere. The other part of the integrative medicine program is looking at those types of mind-body techniques such as yoga, meditation, imagery. These are all things that can be taught and service members can take with them. So we've taken a look, and so we have patients that have been doing extraordinarily well over the last 9 years. But the question always comes down to, what's the biology behind it? And so we've started taking a look at pilot studies at three major aspects. One, taking a look at the autonomic disturbance. And we've been looking at patients who have utilized over 45 hours over the 4-week intensive outpatient program of integrative medicine and finding that that actually has an effect on cerebral vasomotor reactivity. So we're actually finding an improvement of cerebral blood flow in our service members who had been injured and have disruption of their autonomics, both from traumatic brain injury as well as operational stressors. The second, we're finding changes in oscillatory patterns in the brain. And so we're actually seeing where with treatment, patients who have hypervigilance have a change in their oscillatory patterns in the fusiform gyrus and other areas of the brain that have been associated with, and we're finding associated with, the hypervigilance. And last is looking at genetics and genomics, which I think is ripe for study. And one of the things that we're finding over our 4-week period is that the utilization of these integrative techniques have been strongly associated with the reduction in the activation and downregulation of inflammatory mediators, and in the last several weeks of care are associated with an upregulation of genes that are involved in neuritic growth, axonal growth, synaptogenesis, and vasculogenesis. These pilot studies need to be expanded, but there's signal that can be seen even in a 4-week program. We believe that these things would help with the evidence base. Once you can marry the evidence base to treatments that are extraordinarily cheap to deliver and people can do on their own once they go home, now you have a model of care that can be folded into the rest of an interdisciplinary care and a healthcare system, military health system, the VA system, that actually is implementable across the board without saying, oh, it can only be done at a NICO or it can only be done at a polytrauma center. It can be done anywhere in the country.
Mm-hmm. And the only thing I would add to that, I mean, obviously, as everyone has said, prevention is probably the single best way to reduce costs if you can. That's obvious. But however, I do think it's important to understand sources of exposure. I mean, I think we all know that there are sources of exposure that you can't avoid. Driving a car, in theater, there's things that you have to do that expose you to shock waves and mechanical stress. However, I think there are ways to measure that, and then if we can understand the exposure, you can try to mitigate it, and if you mitigate the exposure, then you can reduce the need for healthcare, and part of that's through wearables like sensors that can detect forces exerted to head. We are piloting this mouth guard technology that we've developed at Wake Forest in a sports setting, and what we're finding is that all head impacts are not the same, that some are worse than others, and there are certain settings where impacts are worse than others, and we can start to engineer what's going on in the field to reduce the exposure. And if you reduce the exposure, you have less need for healthcare. So that's number one, is understanding the exposure, mitigating that exposure. Number two is using evidence to triage patients. Right now, if someone comes to the emergency room, whether it's level 1 trauma or not level 1 trauma, from what I see in my perspective from imaging is that people are imaged indiscriminately so that everyone gets imaged. Every single person gets the same kind of protocol. Well, perhaps that's not the best approach. It's certainly not the most cost-effective approach. And if we could find ways, whether that's through genetic testing, through blood biomarkers, through physical exam, through other means to screen who we then apply expensive diagnostic tests to, that would reduce the cost. And then third, if we can reduce the cost of the technology itself. I mean, the ideal situation for me as a simple country neuroradiologist is you would image everybody if it was only, $1, and you had the, bandwidth and man and woman power and computational power to, fully explore those data, because there's lots of granular data in imaging. It's just, if it's expensive, then we don't need to be doing it on everybody, and we need more judicious and strategic ways to apply that in the most cost-effective way.
So this is really the opportunity to be talking about implementation science, thanks to you, Dr. Cifu. And I guess I'm wondering if this is a science, then what can we learn from other examples, other health conditions where implementation has been more effective? Are there lessons learned that we can apply to brain injury?
Yeah, I did the state-of-the-art Google search for implementation science in brain injury, and the first 12 articles are all unique dives into how poorly folks have done with everything from acute severe to chronic mild implementation, implementing clinical practice guidelines, standards, protocols. And each of them offered a series of information, which is in the 80-page report. We pulled out and said, there's really some common themes. If we can't learn from the National Cancer Institute, if we can't learn from, cardiology, there are standard protocols when folks come in with an MI or come in with chest pain that are, the heart's pretty complicated. I'm a brain guy, so the heart just, provides circulation, but I'm pretty sure there's more than that going on in the heart, right? And so, if we can standardize that in the standard approach in an ED as well as in a cath lab or in the cardiologist's office, and same thing with cancer for sure, we can be doing that, but there are guides, there's information in these articles and that are in the lovely report that was put together for this, which we will augment, that we can all learn about how to implement. But the key thing is keep it simple. I mean, particularly, when we talk about military and the VA, when you have massive populations or there's an acute surge of patients, complexity isn't your friend. If you can't be if you can't be implementing it consistently, you might as well not be doing it. There are some questions, so hands, sure. I don't want to distract from that.
Hi, my name is Lisa Brenner. I agree with Dr. Cifu, and I spent a lot of my time in mental health in addition to rehab, and I would say this is one area that mental health is actually a little bit ahead, not that they are implementing everything as well as oncology, but there are a whole brand of scientists, implementation and dissemination scientists, who this is what they do all day, every day. They don't think about biomarkers. They don't think about clinical trials. They think about implementation and dissemination science. And so I don't know that many rehab folks who are implementation dissemination experts. And so how do we bring those people here? They have their own theories, actually. There's entire theories about implementation. And if you write a grant to the VA funding for implementation and don't use those theories, you will not get funded. And so how do we, I don't think we need to recreate this, but we definitely need to be borrowing and encouraging those scientists to work with us, because I don't believe they are right now.
Yeah, and without stealing too much of the time here, I mean, as part of the VA and DoD's clinical practice guidelines program, there was an entire office of implementation dissemination science, or there's a team that does this. There are some scientists and there's some real practical folks. And what we need to do if we want to have a little muscle and push is to say, well, we consider brain injury to be and mental health related conditions to be the signature injury of the latest conflicts and probably any future ones. So let's put more of the resources, time, and energy into actually implementing and disseminating what comes out of the CPG process, as has been done for other, again, in cancer, in veterans, as well as in heart disease, there are more robust implementation programs. So I've actually talked to the folks at Cohen and in mental health as well.
Yeah.
So those people do exist. We know them. I work with them, but we haven't gotten top drawer, top tier support in that because there's competing priorities. But that could be something that could come out of this conference, Dallas and others. Let's say, hey, enough with putting all the money into new research, that's important, but let's actually disseminate what we've already got.
And just to add on to that, VA has a whole arm called Query,
Yes,
that this
of course.
is what they do. The other thing I would say, I mean, because there's implementation at all stages, but some of this is push and pull. So how do we encourage providers, create champions, but also how do we write CPGs in a way that we have metrics, that then we can go back and look at medical records and provide audit and feedback to providers around actually doing these things? How can we create sale measures actually so that medical directors care because their bonuses are based on the fact that these things are done? So how do we do all these things from the bottom up, but also from the top down to encourage implementation?
That would make a wonderful grant, Lisa, as we talked about last night at dinner.
Anyone else? You talked about keeping it simple. What are some simple messages that you or others on the panel would say need to be part of kind of public awareness and also clinician awareness around the country?
Yeah, you know, I hate, this might be controversial, but I think we do need to stop saying that there are no evidence-based approaches to the symptoms related to TBI, because that discourages people right away from saying, well, it's not evidence-based, therefore I can do whatever. Yeah, not so much. I mean, there is not a single approach to the care of post-traumatic headaches, nor to one for sleep disorders, but there are algorithmic approaches that are simple and that are published. And to all the Canadians out there, the Ontario Neurotrauma Guidelines for concussion are awesome. Best out there. Simple, focused, symptom-based. I love the VA one too. I was part of that, but Canadians rocked it, all right? So I think the first thing is we need to downplay that we scientists are still doing all this great work. We are. But what's out there is pretty good. And I think if we don't start to use it and see if you are 92% on the algorithm, what are your outcomes versus 60%? You know, let's look at that research, Lisa and others. And so I would say the first step is let's stop poo-pooing what's out there. You know, that isn't getting us places. So that would be the first step I would advocate. Other people?
Yeah. No, I think the synchronization of things that are working is what's necessary. And again, to the point again of having a network of centers that can push forward on particular items of treatment need to be able to be laid on top of, first and foremost, centers that are doing what we know works already. And we do have, from the service members on the DoD side, we have service members who have those diagnoses of post-concussive symptoms, post-traumatic stress symptoms, going back to clinical operations and combat operations. So we know we have the ability to be effective. Now we need to start synchronizing that and moving individual treatments forward.
It's relatively easy to imagine, dealing more effectively with sleep problems or headaches than we are right now. But obviously part of good TBI care is dealing with mental health issues, which is a whole other, fish to fry. And family issues. Are there things we can do to make progress there? Because we know that people heal so much as part of a family, and the impacts on family are so great.
No, I think, and it's a great point. And I think family should be part of both the education and treatment. One of the things that again, we advocate for is to have service members' families come to the NICO when they're at their intensive outpatient program to begin to learn and understand what are the injuries that have occurred, how does that affect their loved one's response to the world, both from a neurological and behavioral health setting, and how do they as a family come up with strategies to work smarter and not harder when you're having difficulties with hearing disturbances and not being able to move and do things as fast as you used to. A lot of our service members will say, gosh, it takes me 2 hours with 80% effort to get the same thing done I used to be able to do 5 years ago in an hour with 20% effort. And so at the end of the day, they're tired. Well, if you recognize that as a component, how do you readjust family life? How do you readjust? How do you not lose the things that are fun, the things that are spontaneous in life, just because you're trying to recover from all the effort you're putting in to being a hard charger and top performer? There was a comment said before, when you have even a small incremental decrease in cognitive ability, you may say, oh, well, you still look pretty good, but the person isn't able to perform the way they want to, and so they work harder, they're more fatigued at the end of the day, and understanding those concepts of what happens to a person and stopping them from being what they want to be is not just an individual event, it's an event that a family, friends, their support system needs to understand and readdress lifestyle changes that actually enhances their ability to live life without those stressors.
Dr. Hack.
Thank you very much. It's been a great discussion, a very important point. Fundamental to implementation is actually the process of checking if people are implementing. In the severe brain injury area, the trauma centers are all monitored and how well they're following the guidelines. And I don't think we have a solution for this. I think we need to give some thought to is how do we go about checking on more of the broader, like the pediatricians and so on, what process of certification and so on can we put in place? And this gets into policy and gets into governmental affairs and all that kind of stuff. So put some thought in. But thank you. Great discussion. Appreciate it. We're running a little bit late. Let's get to our break here.
I did want to say in response to your comment, Dr. Hack, as a physician who I probably do most of my compliance type stuff, between midnight and 3 a.m. or when I'm on vacation or when I'm, was planning on watching a movie with my kid or something like that. You pull out the computer and you listen to your city training or whatever it is. And the last thing doctors need or want is more compliance testing. It's probably the least productive way of encouraging physicians to do something. So we have to come up with a strategy other than that. I'm not sure what it is. I don't have a solution for you. I would just point out that most doctors hate it.